So, we've talked a lot about antiplatelet therapy, and I was just talking about collaboration between cardiologists and endocrinologists, and obviously with primary care, nephrology, as well as other specialties, vascular medicine, vascular surgery. But we're focusing now on antiplatelet therapy, appropriately so, based on the context of our symposium. But in actual clinical practice, if someone has diabetes, there's lots of other things to think about. Their LDL cholesterol control, their triglycerides, their blood pressure, and their glucose. And maybe Gabriel, I could just start with you. What is your algorithm to the patient with diabetes at high cardiovascular risk? You could call it primary prevention or secondary prevention if you're going to make a distinction in this regard. But what do you do working down that sort of algorithm of different risk factors?
Yeah, like many clinicians, I have my little checklist of preventive goals that I go down, and starts with blood pressure. Is blood pressure at goal? LDL cholesterol, is it at goal? Obviously, glucose and HbA1c, is it at goal? And then I'll go to prevention of thrombotic ischemic events, and have I done the optimal intervention in terms of antiplatelet agents or antithrombotic therapy to prevent events in that patient? So that would be my standard approach. Now the armamentarium for preventive interventions has become so diverse and so rich in recent years that now an issue is the polypharmacy, the choice between agents, the cost, the adherence of patients. These are becoming real issues in diabetes, and diabetic patients often end up with very, very long prescriptions. But I think the idea that we shouldn't focus solely on glucose, as Dr. Leader pointed out, but also have a much broader view of the various goals that we need to achieve, I think is probably the way to go.
Yeah, I think that's really good advice. I think that, myself, I do try to get the LDL as low as possible with obviously the highest dose of statin that can be tolerated. Ezetimibe is needed, and assuming cost isn't a barrier, PCSK9 inhibitors were needed, especially if the LDL cholesterol remains above 100 in high-risk patients, in particular secondary and tertiary prevention. Likewise, if the triglycerides are elevated, I typically start icosapent ethyl based on reducing and observations there. Blood pressure control, I usually aim, pretty aggressively, assuming side effects from blood pressure medicines or blood pressure itself aren't rate limiting. And now, with respect to glucose, there's just between the SGLT2 inhibitors and GLP-1 agonists, great choices where, again, putting cost issues aside, I'd say that the majority of patients with diabetes should be on one or both of these agents. Well, speaking of things that the three of us have worked on together, Soloist and SCORED are two trials of an SGLT2 inhibitor that just got presented and published at the AHA and in New England Journal since the time of our symposium, but prior to the time of this particular taping. Larry, maybe I can just start with you and then ping back to Gabriel specifically to talk a little bit about SGLT2 inhibitors and how they fit in. Of course, we want to get antiplatelets on board. Of course, we want to get the lipids and blood pressure under control. But what about SGLT2 inhibition?
Right. So the SGLT2 inhibitor story is becoming more and more exciting as we learn more and more about what we thought were drugs with simple mechanism of action that you pee out more glucose, and yet now we're seeing all these remarkable benefits. So of course, we had the first wave of cardiovascular outcome trials that showed that in high-risk patients with diabetes, these drugs will reduce the risk for MACE endpoints, for major adverse cardiovascular events. We then had trials done in patients with kidney disease, showing that these drugs will decrease progression of kidney disease. We have patients with HFrEF, in which the addition of these agents may be also used to treat HFrEF, both in patients with and without diabetes. And I should also mention that even the kidney benefit has now also been shown in people without diabetes. This brings us to the most recent trials with sotagliflozin, which, unlike the previous drugs, which are SGLT2 inhibitors, sotagliflozin, not yet approved, is both an SGLT2 and SGLT1 inhibitor. And maybe I'll pass it on to Gabrielle to review these recent results.
Yeah, this was exciting. The first trial and the largest trial is SCORED, which was sort of a conventional safety type of trial, as is now regularly required for new anti-diabetic agents or glucose-lowering agents, should I say. Originally designed to demonstrate safety in terms of preventing CV death, MI, and stroke, and it did achieve that. But this is a large trial of 10,000 patients, if I didn't mention this. But it also looked at CV death and heart failure, which everybody is now becoming much more aware of the importance in patients with diabetes. And it also prevented CV death and heart failure. And it had the conventional benefits of SGLT2 inhibitors on blood pressure, on body weight, on renal function, on glucose lowering. And interestingly, the population that was enrolled in SCORED was a population with moderate to severe chronic kidney disease, in which theoretically the efficacy of SGLT2 inhibitors tends to diminish with renal function. And possibly because of the SGLT1 inhibition, the efficacy, if anything, the efficacy in terms of glucose lowering was absolutely maintained across the various strata of kidney function. So that was interesting. But to me, the even more interesting findings come from the second trial, SOLOIST, which is a trial that looked at heart failure. In fact, it looked at a subgroup of patients with heart failure that has not been tackled before. We've had many studies that looked at prevention of heart failure in diabetics. Then we've had studies more recently that demonstrated that some agents, including SGLT2 inhibitors, could treat patients with established heart failure with reduced ejection fraction. But now SOLOIST is tackling patients who've just been admitted to the hospital and treated for acute heart failure. So they're post-acute heart failure patients, and it's a very severe lot. In fact, when you look at the outcomes in that population, almost all of the patients experienced an adverse outcome in the placebo arm over the 18 months of follow-up. That was a smaller trial because it was halted prematurely, not due to overwhelming efficacy or safety issues, but merely because of funding issues in the context of the COVID pandemic. And I think this is one more issue related to how COVID-19 disrupts clinical trials and clinical research. Nevertheless, despite being halted prematurely, despite not enrolling the totality of patients that it was planned to enroll, the study demonstrated a very substantial reduction in cardiovascular death and heart failure. And this is true regardless of how you look at it. The type of outcomes, whether they're total events, first events, CV death and heart failure admissions, or CV death, heart failure admissions, and acute heart failure decompensations. Whether you look at early events, you see that there's benefit even after a few weeks of therapy, or late events. And the benefit is quite substantial in the population, with approximately a reduction by a third of the event rate with sotagliflozin. The also quite exciting observation, both from SOLOIST and pooled analysis from SOLOIST and SCORED, is that the benefit appeared to be consistent across the various types of heart failure and the strata of ejection fraction, suggesting that we may have the first demonstration in a clinical trial in a randomized setting that inhibition of SGLT2/1 reduces heart failure with preserved ejection fraction. That would be a terrific finding for our patients. Now, there were some side effects, as in all trials with these glucose-lowering agents, and in particular in SOLOIST, there was an increased frequency of diarrhea and hypoglycemia. That has to be put in the context of side effects that are known with this class of agents. But I think it's really, really intriguing to see these striking benefits over a relatively small population and a relatively short amount of time across the various strata of patients. So very, very exciting news, I think, for the field.
Yeah, I think that's really a beautiful summary. And I think you're right among many points. I believe that in SOLOIST and SCORED, we've collectively produced the first randomized trial evidence, prospective evidence that SGLT2 inhibitors work in HFpEF. The first time any drug, in fact, has been I think, pretty conclusively shown to work in HFpEF, though that's not to diminish the importance of any of the ongoing trials with SGLT2 inhibitors. I think those should all continue.